Thank you so much. I'm delighted to be here, and I can tell you that I recognize quite a few of you in the audience. Our paths have crossed at various times, and it's so nice to see all of you here. I hope this turns out to be a very useful occasion for all of you in terms of what we're going to talk about. I would ask you to hold your questions until the end. I'll be happy to answer questions, but let me go through the material and tell you what's on my mind, because I may end up answering a lot of the questions that you have, and then we'll do that afterwards. So the reason that stroke is so important is that not only is it a leading cause of death, but it is the #1 cause of permanent disability in the United States. It is the #1 cause for ending up in a nursing home. And we all don't want either of those things to happen. We do not. So the first thing is that we want to do everything we can to prevent a stroke. We're going to talk a lot about that. And if you can't prevent it, then you want to know what to do to treat it. And we've now developed some very, very excellent, effective treatments for stroke. But as you will hear, time is critical. When you have symptoms of a stroke, time is critical, because if you wait too long to get to the hospital, it's too late to apply the treatments. And so the take-home message, as it is for this talk and every talk I give, when you're having symptoms that might be a stroke, you need to call 911, have an ambulance come, get you to the hospital right away, okay? So the World Health Organization identified what they consider to be the 10 most important global health challenges, and 4 of them are brain-related. Okay, stroke, dementia, traumatic brain injury, and depression, all brain-related. Now today we're going to talk about the first one, stroke. At other times we might talk about the others, and I'm happy to do that at another time, but today we're going to talk about stroke. And then if you look at what the World Health Organization calls the global burden of diseases, this is worldwide. Stroke ranks as second worldwide as a cause of death, just second to ischemic heart disease. Okay, stroke is #2. You'll notice that some other neurological problems rank up there as well in terms of causes of disability, and they define disability as a physical ailment which prevents you from going to work. That's how the WHO defines disability. So just out of curiosity, it turns out that low back pain is the #1 cause for people to stay home from work. Interesting problem, okay? Low back pain is so common. But we're not going to talk about that, but I thought it'd be interesting to just see what's up here, okay? So let's talk about stroke specifically. In 2016 in the U.S., 795,000 people, almost 800,000 people, suffered a new or recurrent stroke. That's a stroke every 40 seconds. In the United States, as opposed to the entire world, stroke is the 5th leading cause of death. When I started in this field 35 years ago, stroke was the 3rd leading cause of death in the U.S., and our treatments have become so effective that we've pushed it down to #5 instead of #3, which is a good thing. So we've done very well. However, the total number of people who have strokes keeps getting larger, keeps increasing, and the reason for that is that our population is aging. The proportion of our population over the age of 65 has dramatically increased. If you look at the 1960s, about 10% of our population was over the age of 65. It's now over 15%, approaching 20%. So the aging population makes the numbers go up, because most people with a stroke are over the age of 60. So, as I said earlier, it's the leading cause of adult disability, the main reason, the number one reason for someone to end up in a nursing home. So we don't want that. There are about 7 million stroke survivors in the U.S. Whoops, sorry about that. So, let's talk about for a second what a stroke really is and what causes it. There are two kinds of strokes. The vast majority are what we call ischemic stroke, which means a blood vessel that supplies blood to the brain becomes blocked off with a blood clot. The blood doesn't get to the brain tissue dies. It's the same thing that happens when you have a heart attack. A heart attack is the artery that goes to your heart becomes blocked, and the heart tissue dies. In a stroke, the artery that goes to the brain is blocked, and the brain tissue dies. This accounts for about 85% of strokes in the United States. The other 15% are what we call a bleeding stroke, where an artery bursts and there's bleeding that occurs. That occurs in people that have brain aneurysms, for example. But those are relatively rare, and I'm really going to talk about the ischemic strokes, what is demonstrated on this slide, where a blood clot blocks an artery that's going to the brain, and this part of the brain is now damaged or dead as a result of lack of oxygen and sugar going to the brain. This is a CAT scan of a person that has one of the most common forms of an ischemic stroke. This is occlusion, blockage of what's called the middle cerebral artery. The stroke area is this big dark area. This dark area is dead brain from the stroke, and it's a very large area. It probably takes up about a third of the brain, and as you can imagine, this person is devastated by this. This person is paralyzed completely on one side, unable to walk, unable to take care of themselves, either bedbound at home or in a nursing home, alive, but totally disabled. So this is a common form of stroke, one of the worst kinds that we really want to prevent, and if it occurs, we want to treat it to not let it get to the point where the brain itself is dead. Now, a lot of people have had a very pessimistic view of this. When I was in training to become a neurologist, I worked in a large department, an academic medical center. We had 150 neurologists in that department, a big department, all very prominent people. And out of those 150 neurologists, not a single one had any interest in taking care of a patient with a stroke. Not a single one. And if a stroke patient came to the hospital, they were stuck in a corner somewhere, and it was like, oh, you had a stroke. Oh, so sorry to hear that. And there was no treatment, there was nothing to be done, and that person was put in a corner. They stayed in the hospital for a period of time. If they got better, great. If they didn't get better, off to the nursing home. That's the way it worked. And part of that reason was that there was no treatment, but also, in my opinion, part of the reason was this, that these were mostly older people. And in my opinion, going back, 30 years ago, 40 years ago, I think there was a real neglect of older people. And now things are better now. I think the reason things are better now is that there's so many more older people, you have a lot of clout. But back then, I really think nobody cared so much. Oh, had a stroke, he's 75 years old, so what, who cares? That's life, that's the way it goes. And that really was the attitude. But now it's very different. We don't feel that way anymore. And so the fact that most strokes occur over the age of 60, so what, okay? You can be over 60 or 70 or 80 or 90 and otherwise be a vibrant, active person who deserves to be treated like anybody else. So I think the attitude has changed, but let's keep in mind that as you get older, your chance of having a stroke increases. But the most important thing I could say, and the good news, is that most strokes can be prevented. In fact, 80% of strokes that we're seeing now can be prevented. And that involves all types of strokes, if you do the right things to take care of yourself, and these are things that you have to do. They're not things that your doctor is going to do. Your doctor can do some things, but most of this has to do with good health habits, and we're going to talk about it. You can prevent 80% of all strokes. And it's never too late to do these things. So the reason is that there are modifiable risk factors. Your age is not modified. You can't, you can't turn back the clock and make yourself younger than you are. I mean, you can lie about your age if you want to, but that's not going to really help you in any way. So, but I don't think you need to dwell on that. Your age is your age, and you leave it at that. But all of these things can be either modified or, in fact, eliminated. So, for example, if you have what's called a TIA, some people call it a mini stroke. It's a very brief episode like a stroke, but it clears up in 10 or 15 minutes. If you have something like that, it's a warning sign that there's something going on in your system to be taken care of. And in a situation like that, you find out what caused that mini stroke, and you can eliminate the problem. And one reason is, for example, you can have a blockage of an artery in your neck, and that's a fixable thing. Okay, so you want to identify these things. In the room, hypertension, high blood pressure, I can tell you right now that 2/3 of all of you sitting in this room, 2/3 of you have high blood pressure. I know that for a fact, even though I don't know all of you, because over the age of 60, about 60 to 70% of people have high blood pressure. You need to treat it aggressively, and you need to start early, okay? As soon as it's identified, you need to treat it and continue to treat it. In the United States, where we think we have good health care, only 50% of the people who have high blood pressure even know they have high blood pressure, and of those, only 60% are being properly treated. So there are millions of people with high blood pressure not being properly treated. Cardiac disease, and the most important heart disease related to stroke, is a heart rhythm problem called atrial fibrillation. Okay? I'd say, probably 20% of you sitting here have atrial fibrillation. Hopefully you know it, and hopefully it's being treated. And the reason atrial fibrillation is such a problem is that it allows blood clots to form in the heart, and then those blood clots travel to your brain and cause strokes. The CAT scan picture I showed you, that was a blood clot from someone who had atrial fibrillation. That's the kind of stroke you get, a really bad one. So your doctor has to evaluate you for possible cardiac disease, particularly atrial fibrillation. And guess what? Atrial fibrillation increases with age. As you get older, more and more people are going to have atrial fibrillation. So it's another thing you have to pay attention to. Diabetes and glucose metabolism. Diabetes will double or triple your risk of having a stroke due to a whole variety of causes, but that can be reversed if you manage your diabetes very, very carefully. And the fundamental way to treat diabetes, if you haven't been told this yet, it's not with a pill, it's not with insulin, it's with diet and exercise is the fundamental way to treat diabetes. And the pills and the insulin, quite frankly, are in addition to that. But if you have a proper diet and exercise, your diabetes will be under good control. Carotid artery disease. Carotid arteries, there are two arteries in your neck, one on the right, one on the left. They supply 80% of the blood to your brain. If you have a blockage of these arteries due to atherosclerosis, that can cause a stroke. But blockage in these arteries can be treated. The arteries can be cleaned out, or a stent can be placed. So these are all treatable things. Cigarette smoking. I won't ask for a hands of who still smokes. I'll just say, those of you who still smoke are nuts. I mean, you gotta stop smoking. I mean, there's just no explanation for that one. Okay, and smoking will double or triple your risk of having not just a stroke, but a heart attack and cancer and 50 other things. Okay, so you got to stop that. I mean, in the United States, still 20% of the population still smoke cigarettes, 20%. Yeah. Lifestyle factors, very important. Obesity increases your risk of stroke. A sedentary lifestyle increases your risk of stroke. Bad diet increases your risk. Illicit drug use, emotional stress. Now, the emotional stress part's interesting because emotional stress can be caused by all sorts of things you may not think about. So, for example, we know that for the 2 weeks following a birthday, you don't have a birthday every year, for 2 weeks following a birthday, your risk of having a stroke and a heart attack doubles after your birthday. Because it turns out a birthday becomes a stress. Now you say, well, why would that be? It's my birthday. Well, like, should I have a party or not have a party? Should I invite this cousin or that cousin? Or are they going to be upset or angry? Should I have a cake or no cake? Or people get so worked up over things so that for 2 weeks after a birthday, due to the stress, your risk of stroke and heart attack goes up pretty dramatically. So we have to learn to manage our stresses in a healthy way. And that's important, okay? Oral contraceptives increase your risk of a stroke. Turns out that pregnancy increases your risk of a stroke in addition to that. Now, this is a carotid artery that was blocked up with atherosclerosis, and this is a surgical specimen. This was removed from someone's carotid artery in order to prevent a stroke. This is supposed to be the opening of the artery. It's right, that little dot is all that's left. This is all fatty plaque. That's all atherosclerosis. So, look, this is an awful thing, and it can be prevented with medical treatment, but once you get this, it can be treated with surgical removal, and that will prevent a stroke. And the way the surgery is done is portrayed in this diagram. This is the part of the carotid artery. The surgeon opens it up and basically pulls out the atherosclerotic plaque and then sews it back up again, and you're as good as new. And this is an operation which is durable for life. It almost never has to be repeated. You have it one time, and that's the end of it. However, when you have an operation like this, you then need to be on medicine to prevent this from happening again. So the medicines that we prescribe for patients are what are called the statins. Lipitor and Zocor and Crestor and all those drugs called statins, which prevent the development of atherosclerotic plaque in these arteries. And then you can also have a carotid stent if you don't want to have the surgery. And carotid stents and surgery for this are equal in their benefit. They're equal. One is not better than the other. They work just as well. And this is what the stent looks like. It's a little mesh tube, and this is the blockage in the carotid artery. You see where that dark line suddenly narrows down. This is just another view of it. This is the normal artery, and then it all of a sudden gets narrowed down there, and then the stent is placed. You can see the mesh, and it opens the whole thing up. So this procedure is done in a minimally invasive way through a catheter. It doesn't require an operation. Most patients go home the next day. So you can have a stent or you can have surgery. Either one works equally well. Both just as good. And then you want to do what we call a self-assessment of your risk factors, okay? And you can, I'm sure you all have computers. I don't know if we're handing this out or not. Are we? We could. You go to the National Stroke Association website. This is on their computer website, and you can download it or simply look at it. And you've got the risk factors listed: blood pressure, atrial fibrillation, smoking, cholesterol, diabetes, all these things. And red is high risk, yellow is caution, and green is low risk. And you want to get yourself from red to green, okay? And quite frankly, you could show this to your doctor and have your doctor help you work on this. Most people can figure this out themselves, and they do it themselves, okay? I'm a great believer in people being responsible for their own lives and taking care of themselves. I don't think you can rely on any doctor to really take care of you the way you should be taking care of yourself. You got to do it yourself. I think that's really important. And if you get something like this, you can address all of these items based on how you score. And if you need help from your doctor, you can get help from your doctor, particularly in dealing with the cholesterol. Everything else you can do yourself. And if you go from red to green, you're going to reduce your risk of having a stroke by 80%. That's what's going to happen. This really works. This really makes a big difference. Now, people who have strokes are not all over the age of 60 or the age of 65, okay? You probably recognize these two young people. Sharon Stone, a very well-known actress. Teddy Bruschi was recently an award-winning all-star football player for the New England Patriots. Sharon Stone had a ruptured brain aneurysm, almost died, but was treated very, very successfully at UCLA Medical Center, recovered, and is back doing whatever she does. And Teddy Bruschi had a stroke from a blood clot that went from his leg through his heart up to his brain while he was flying back from a football game from Hawaii to Boston. He was on a long flight, and a blood clot formed while he was sitting on a long airplane flight. He woke up with a stroke, a pretty serious one, but he made a full recovery and actually went back to playing football.
Wow.
And so the difference between a stroke in a young person and an older person, in general, because the strokes are the same, it's that young people make better recoveries than older people because they have a greater capacity for new brain cells to develop and grow than older people do. Okay, so, but that makes it even more important for prevention in these cases. And in both of these cases, Sharon Stone, she did not know she had an aneurysm, and Teddy Bruschi did not know that he had a hole in his heart, which allowed this blood clot to travel from his leg through his heart up to his brain. So there are things that we have that we don't know about. So let's talk about the really great advances that have occurred now in the treatment of stroke. Up until now, we're talking about prevention. And again, I believe prevention is number one, the most important thing, much better than treatment. But 1995, that is now 22 years ago, 1995 was the study that was published that proved that what we call thrombolytic drugs, or TPA, administered in someone after a stroke can result in recovery if given fast enough. So how fast is fast? Well, this TPA study in 1995 required that patients be treated in under 3 hours, but half were treated in under 90 minutes. And what we found and saw right away is that if you were treated with this drug in under 90 minutes, and that's from the onset of symptoms until the time this drug is injected in your arm, if you're treated in under 90 minutes, your chance of making a complete recovery is double than if you wait for 3 hours. So we learned right away that the faster you administer the drug, the higher the probability of recovery, which is why we say time is so important. Some people use the expression, time is brain. Every minute that passes before we can reopen this blocked artery, we will lose 1.9 million brain cells every minute that passes. So every minute counts. And we discovered that right away in 1995. In 1996, the FDA, the Food and Drug Administration, approved this as the only approved treatment for stroke, and to this day, it still is the only approved treatment for stroke, although there are other things we use that are not approved by the FDA, but we kind of use them anyway. But this is the only thing approved, so 1996. But it took a good 10 years before this was fully accepted by the medical community. took 10 years before doctors in general agreed and said, okay, we're now going to use this drug to treat people. The medical profession in general is a very conservative group. It's very hard to get them to try anything that's really new. And this was really new, and most doctors were deathly afraid of this drug. They kept thinking that, oh my God, I'm going to give this clot-busting drug, and patients are they're going to bleed, and they're going to die from the drug, and all these terrible things are going to happen. And it took a good 10 years before we got people to really start using it. But it definitely worked in terms of the recovery. But we also learned, as I said, that with the passing of time, it loses its effectiveness. So it's most effective if given very quickly. So if you give it within 60 minutes of onset of symptoms, the chance of making a good outcome is 3 times what it is if you wait 4 hours or 4.5 hours. By the time you get to 4.5 hours, it has no benefit at all. No benefit at all. And the reason for that is that the blood clot starts to solidify. The blood clot becomes more and harder, and you can't dissolve it anymore. So you want to get the drug in before the blood clot tightens up and it can be dissolved. So the faster you give this drug, the better. Another reason why, if you have symptoms of a stroke, such as your face is drooping, your arm is weak, you lose your speech, you suddenly can't walk, you suddenly get very dizzy. When those things happen, you got to call 911 and get to the hospital. Don't delay. If you sit around and wait, you're going to miss the opportunity to have treatment. So we learned this right away, that as time passes, you lose the ability. And this, I told you, a way of looking at this is the number of neurons, those are brain cells, lost per minute, 1.9 per minute. Per hour, 120 million brain cells. That's a lot of brain cells. You don't want to lose those. You can translate that into accelerated aging. So if you lose an hour during the stroke, it adds 3.6 years to your life. That's one way of looking at it. I look at it by the number of brain cells lost, which is going to affect your ability to think and remember and to walk and talk and to be a human being. I mean, you lose those abilities. So speed is really important. Now, at our hospital, and at most major hospitals, certainly in New York City and around the country, we are very fast at treating patients. So, for example, our guidelines are from the time you hit the front door of the hospital, if you're coming in by ambulance, we need to get you through all of the diagnostic tests and get your treatment started within 60 minutes. That's our target. And we now do that 100% of the time, 100% of the time. Compared to other hospitals around the country, only hit about 70% of the time. I just saw a patient in the hospital before I came here. I went and made rounds with the residents. They showed me a woman who has atrial fibrillation, and she was on a blood-thinning drug that was stopped several weeks ago because she had some stomach bleeding, and the drug was stopped, and she had a big stroke exactly like the one I showed you on the CAT scan. She came to our emergency department. They got her through testing and started her treatment. They gave her the intravenous thrombolytic in 26 minutes. They got it done in 26 minutes. They literally ran her through the hallway to get the tests done, and the treatment was administered within 26 minutes. So they are really fast. The problem, though, is no matter how fast you do it in the hospital, people still delay. They don't call 911 fast enough, or they don't come to the hospital, or they say, you know, my arm suddenly got droopy and my face got droopy. Let me sit down and have a cup of tea and see how I feel in an hour. And if I don't feel better in an hour, oh, well, let me call my daughter and see what she thinks. And before you know it, 2 hours have passed and you've missed the opportunity. So you can't do that. You really have to call immediately, okay? Because we'll treat you fast, but if you don't get to the hospital, we can't do it. So it turns out that of all the stroke patients we see, we're only able to give about 10%, 1 out of 10, these drugs because they don't get to the hospital fast enough. Only 1 out of 10 get treated. Okay, now, the next step is to pull the clot out of the brain, what's called mechanical thrombectomy. There's several different devices that we use. The first one that was developed actually by our chief of neuroradiology is this one here. It looks like a little corkscrew, and the person who developed it, Pierre Gobin, is French, and I'm sure that he drinks a lot of French wine and often uses a corkscrew to open the bottle of wine. And he was like, well, let me make a corkscrew that I can use it like I pull the cork out, put it in the clot, and pull the clot out. And in fact, that's what he developed. And it does work, but it doesn't work that well. It doesn't work well enough to get the patients better, but it does work. And the next thing developed was a little suction catheter, so it sucks the blood clot out. And that works, but it also, so one was developed in 2004, this was developed in 2008. They work, but they don't work that well. So the next development was really a revolutionary change. 2015, there were 5 separate clinical trials reported at an international stroke meeting in 2015 using a new device. This device, it's a stent retriever that is inserted into the artery of the brain, and in all of these trials this device showed dramatic benefit in removing the blood clot and showing the patients made excellent recoveries. So we now had a device that really works, and we are now all using this device, and it's being used all around the world, and it's being improved upon. I mean, this device will get better and better as it gets improved. To show you how it works, this is what it looks like. It's collapsed and hides within a catheter. The catheter is pushed up into the artery, pushed up, opened up, and then pulled out, and this is a real one. It pulls the blood clot out, stuck to the catheter, stuck to the stent, and it's pulled out. This device can reopen a blocked artery in the brain 80% of the time. It's pretty good, 80% of the time. Not 100%, but 80% of the time. And here's an example. Okay, this is an X-ray called an angiogram. This dark is the artery, is the blood vessel. And this is the carotid artery. This is the middle cerebral artery. And you notice right there, suddenly it stops because it's totally blocked. There's a blood clot right there, and no blood flow goes past that spot. Totally blocked. The clot is now removed, and guess now all these blood vessels start filling up again. So this is complete reopening of a blocked blood vessel using one of these devices. And this is what we are trying to accomplish, what you can see here. But again, the same relationship holds in terms of clot extraction, time versus outcome. If you treat the patient within 2.5 hours of onset of symptoms, you have a very high probability of making a full recovery. But as time goes by, you see this curve goes down, and then it hits 0 right about here, right at about 7 hours, 7.5 hours. So if this happens, you have a stroke and you say, well, I'm going to go to bed and I'll see how I feel tomorrow morning, you've completely missed the opportunity. And if you then come in the next day and say, oh, I think I had a stroke, let me go to the hospital now, it's too late. You can't really do much to help you because you've allowed the time period to pass. So time is absolutely critical. But is there a way that we can go even faster? Even faster, cut the time down. Turns out, yes, there is a way that we can go even faster. This is a letter that was written to one of the stroke professional journals by Dr. Klaus Fassbender, who's a neurologist in Hamburg, Germany, in 2003. And in this letter, he proposed building a mobile stroke unit ambulance, an ambulance which is bigger than a normal ambulance, and it has a CAT scanner built into the ambulance, and a doctor goes out with the ambulance in the field to examine the patient, do a CAT scan of the brain, and if the patient has a stroke and is appropriate, they give TPA right in the ambulance. He proposed this, did the first one in 2003 in Hamburg, Germany. It then quickly moved to other cities in Germany, and then it moved to the US. The first one in the US was in 2014 in Houston, Texas. We have deployed a similar ambulance last year, last October. We started operating an ambulance like this in New York City out of our hospital. So we were the first one on the East Coast of the United States to do this. So what's the potential of this mobile stroke unit? Well, it brings the physician and the tools right to the patient. We're out in the field, we go to your house, we go in your house, we examine you in your bedroom, and we take you right to into the ambulance and do the CAT scan right there, and we treat you right there. We don't wait to get back to the hospital emergency room. So treatment is initiated at the scene. It cuts the time to treatment, increases the chance that we're going to be able to give you these therapies which work by shortening the time, and therefore there's a better recovery, better outcome. This is what it looks like inside. It's a compact CAT scanner that is built into the ambulance. Some of the units use a telemedicine model. In other words, they have audio-video systems so that the doctor is not in the ambulance, the doctor is back at the hospital examining you remotely by an audio-visual system. I don't know how many of you have used this. This is now becoming actually quite common. We do it at our hospital in a number of different settings. And at some point we will be doing it with our ambulances as well, because we hope to deploy several of these units. And honestly, as a practical matter, we're not going to have enough neurologists to go riding around on the ambulances, so we're going to have to do it with telemedicine. On the ambulance is paramedics, a nurse, a CT technologist who operates this CAT scanner. I mean, the CAT scanner is a fairly delicate device. The ambulance must be stationary while we're doing the scan. You know what streets in New York City are like, and potholes. You know, you can't be bouncing up and down to do the scan. And the ambulance, in fact, has special stabilizer bars built into it. So when it finds a good parking space, the stabilizer bars come out onto the street and levels the ambulance to make sure it's perfectly level. And then the CAT scanner is turned on, and we can do the scan. And this is what that CAT scan looks like. Now, the interesting thing is, it turns out this is probably not an idea that we thought of ourselves. This is a picture of the very first ambulance in the world, I think. 1869 in New York City, coming out of Bellevue Hospital in 1869. And I'll note that here's the doctor's there, and here's the patient. And notice the patient had a problem with his head. He's got a bandage around his head in 1869. Now, there's no CAT scanner there. It's just the doctor and the patient. But they had the right idea back in 1869. So what's the experience in Europe? The vast experience has been primarily in Berlin, Germany, where they actually now have 2 of these units deployed in Berlin. And they published results of 6,000 patients that they split into those treated by the stroke ambulance and those just treated by a regular ambulance, which brought them back to the emergency department. And what they found is those treated on the stroke ambulance were treated 25 minutes shorter, faster than the other patients. 25 minutes shorter. Well, 1.9 million brain cells per minute times 25 minutes, you know, that's like almost, 50 million brain cells. It makes a big difference. Makes a big difference. So 25 minutes is a big deal in this area, in this field. If we can take 25 minutes off of treatment time, it makes a big difference. I'm sorry that you're not going to be able to probably see the small print here. This is from the paper that was published. STEMO stands for, it's the German term for stroke emergency mobile. That's their name for the ambulance, stroke emergency mobile. That's STEMO. And again, the time from onset of symptoms to administering the thrombolytic drug on a conventional care was 129 minutes. STEMO care was 96 minutes, so it was more than a half an hour of time saved in the German experience. So based on this, and this was just published, based on this, we decided that we wanted to do this, and we started planning this in 2014, but it took us 2 years to make it happen. It's a complicated endeavor. It took us 2 years to make it happen, and we had to get, you know, the laboratory capabilities and scanners and technologists and paramedics. I had to get all of my neurologists to agree to go out and ride on the ambulances, and trust me, they were not so happy about this. Had to twist a few arms, probably broke a few arms, but we got them all to do it. And we had tremendous support from the New York-Presbyterian leadership, and the critical part of this was actually the support and help from our emergency medical services. I don't know if you realize this, but I didn't know it because I never really worked with this team before. New York-Presbyterian Hospital operates over 50 ambulances of all different types. They have transport ambulances, pediatric ambulances, critical care ambulances, and now they have a mobile stroke ambulance. And the paramedics that run this service are absolutely extraordinary, and we work with them now every day. And what I've said is, God forbid I have an emergency, I have a heart attack, or I get sick, or I get run over by a bus, or whatever happens, I want these paramedics to come and take care of me. They are really, really spectacular. I mean, I had no idea how skillful they are. And if it wasn't for them, this would have never worked. They were the most enthusiastic, motivated people I've ever seen. It was not the doctors who really made this successful. It was the EMS paramedic team that did it. So you can feel confident if you call for help and one of our paramedic units comes, you're in excellent hands. I'll tell you that in a second. The easiest way is call 911. I mean, we're connected to the 911 system. If you call 911, now the ambulance is not on duty all the time. It can't be. It's not a 24/7 thing. But just so you understand, we did an analysis. It turns out that 80% of the strokes that occur between the hours of sort of 7 a.m. and 7 p.m. There's an odd thing. So we're running during those hours, but if you call 911 and tell them, I think I'm having a stroke, they will send us out. If you call 911 and just explain what's going on, they may or may not, but we're listening to the radios. In other words, we're listening to the radios, and if we hear something that sounds like it might be a stroke, we go to that site. We're licensed to travel anywhere we want to go. We can pick and choose. We don't have to wait to be called. We listen to the radio, and we just go. So, yeah, sure.
When I had the strokes that I had aphasia. So how do you say it?
You couldn't say anything. No, that's a tough one. Well, no, I don't have a good answer for that, except I hope someone was with you.
Nobody.
No, I mean, look.
But she's okay. She's fine.
You're not the first person that has talked to me about this. I don't have a solution for that one. I mean, some people have these emergency buttons that they can press in their homes, things like that. That's a tough one. I mean, look, were you able to press 911, at least get on the phone?
No.
So how did you, so what, yeah.
I pulled into a parking lot, went into a store, pointed to my phone, and the person who was in the desk called my son, and he called 911.
Okay, all right, well, thank goodness for that. I mean, I think, it's a good thing that you were able to get help like that. I don't have a solution to that one, because when you become aphasic, you can't, yeah, no, that's a big problem. You got to work on that one. So here is the ambulance. This is what it looks like. This is the scanner inside of it. These are results from the first 4 months. This was October, November, December, January. It was in service 80 days during that period of time. It was sent out approximately twice, 2 deployments per shift. It's an 8-hour shift. It was sent out on twice per shift. We transported 30 patients back who we diagnosed with stroke. Only 8 of them required TPA. Only 8 of them of that number. It's a small number, but it's a small number that's an important number because they're patients who probably would not have been able to get it if they had waited to go to the hospital. So, look, this is a preliminary report. This is a brand new program that we started. We'll have more information in another few months. But we're very happy with the way this is going. And if you look at the time metrics that we've been able to show, these 2 bars are the mean time it takes to treat a patient that comes to our emergency rooms. The blue bar is on the Columbia campus uptown on 168th Street. The red bar is this campus at Weill Cornell. It's about 130 minutes. That's a little over 2 hours. And on the ambulance, it's 93 minutes. Okay, so we're saving, over a half an hour, even from the beginning, and we're not as good at this as we're going to get. So, for example, right now it takes us longer on the ambulance to get a CAT scan done than it does in the emergency department, and we're going to shorten that because we should be able to do it very quickly. What I've decided is that our doctor who goes out is taking too long with an examination before the CAT scan is done. So we're going to try to tell them, don't spend all that time doing such a detailed examination. Get the person in the scanner, and once the scan is done, we can then move ahead. You can examine them and do a lot of things afterwards. So these are things that you learn as you're doing it. So we're going to even get faster as time goes by. And then what happened to these patients? Again, it's a small number. Of all the patients that got transported, and this has been found everywhere, only about 50% of them had real strokes, okay? The rest of them had things which we call stroke mimics. What's a stroke mimic? Well, if you have a low blood sugar, it can look like a stroke. If you have a migraine episode, it can look like a stroke. If you have a seizure, it can look like a stroke. So only half of them are actually strokes. And again, only a small number were given TPA because we don't give TPA to the ones that are, quote, mimics, because they're not strokes. This is a picture of only sort of half the team. It's really, the team is double the size of this, but they happened to grab a picture of us while we were doing this to give you an idea. And this is really a labor of love for everyone involved. And I'll give you a little anecdote. If you see this woman right here, she's one of the paramedics who's been on this from day one. She's was so enthusiastic, and I found out this afterwards, I didn't even know. She went to medical school about, 5 or 6 years ago, 7 years ago, and then decided not to continue for some personal reasons, and has been working as a paramedic for the last 5 or 6 years. Did not do a residency, just graduated from medical school and then didn't pursue it. She got so interested in all this that she decided she wanted to do a neurology residency, and she just got into a residency. She's going to start a neurology residency in July because of the work she was doing here. And just goes to show you the enthusiasm of this group. So it's really a fantastic group of people. And this just goes to show you the cities where this is currently active. This was from a few months ago. There are 6 cities in the United States. That's expanded to about 10 cities. Chicago has 2 units. There are 2 units in Ohio. Los Angeles, Boston are ready to go. I just met with someone from New Haven, a neurologist in New Haven this morning. He said they're ready to go in New Haven, Connecticut. So just every city is going to have one or more of these units pretty soon. I mean, it's going to spread very, very rapidly. And I'm going to close with a short video that we produced really for this purpose. I don't know if you have any sound.
almost 800,000 people in the United States will have a stroke.
Can't hear it?
When a stroke occurs,
It's here, but you don't, we hear it here.
passes or retreats, we lose
Make that louder.
1.9 billion brain cells.
Oh, well.
The history of emergency medical services has always been about how quickly we can get patients to the hospital. What we're looking to accomplish here is bringing the emergency department essentially to the patient out in the field.
Trying to figure out.
This ambulance going out into the field.
We could run and get the AV guy if need be. We didn't know. How long is this?
Sorry about sound.
Too low. Can't hear it.
Saving lives and preventing disability for patients without stroke.
In conjunction in partnership with the New York State Fire Department,
Jeff Boxer is this, he's the head of the EMS services for the hospital. So that's why I said it. We never would have been able to get this done without the great help and support of the EMS people. Well, hopefully you'll get an idea. This is actually on the ambulance doing a scan of the patient. It's one of our stroke neurologists, that was Dr. White.
Prior to the patient arriving in New York-Presbyterian,
I'm sorry about the sound.
innovative therapies and always
It's still good to watch. I mean,
Okay.
it's pretty self-evident what's going on.
And you're commentating.
How many of you were fans of the show ER that was on years ago? And you'll remember there was an episode, I think it was Nixon. What was her name?
Cynthia?
Cynthia Nixon. What portrayed a stroke victim that came into the ER. I don't know how many years ago this was. It was quite a while ago, but it was a very excellent portrayal of what goes on. So you could probably go back to YouTube and find an old video. You may want to watch it. Type in ER and type in her name, Cynthia Nixon. You can find that one. So that's the end of today's presentation. Be happy to take any questions or hear your comments. Thank you.
Questions?
Here.
Okay, well, we're actually taking written questions.
Oh
I'm
my
sorry.
God.
Sandy.
Questions.
Yeah, I thought it would be easier.
And then if we had to do something with sounds.
Yes, the sound guy. This is small.
A small aneurysm, okay? So a lot of people have small aneurysms. That we estimate that in the general population, between 2 and 4% of people have small brain aneurysms. So, you know, sitting in this room, probably a couple of you have them. Small aneurysms pose no risk. They pose no risk, as long as they remain very small. So we usually recommend that you have a scan to check the size roughly every 5 years to check it, to make sure it's not getting any bigger. Okay? If it remains small, you've got nothing to worry about. The chance of an aneurysm rupturing, if you harbor one, is about 1 in 200 will actually rupture. The vast majority of them never do, and the small ones never do.
But it's not, but even though you take like aspirin for blood thinner, still no risk.
No, aspirin does not make anything rupture. No, you still should, if you need to take aspirin, you take aspirin. It's not, that won't hurt anything. Yeah, small ones don't cause a problem. Okay, question. If a person has family members who had a stroke, so the question, yes, the answer is if you have a family member that had a stroke, and we're talking about first-degree relatives. First-degree relative is parent, sibling, child. Those are first-degree relatives where you actually share a lot of genes with that person. Yes, if that first-degree relative had a stroke, you have an increased risk of having a stroke. So you should pay special attention to your risk factors in terms of diet and exercise. Now, the one piece of information, advice I give people in general, as you get older, the single most important thing you can do for your good health as you get older is to exercise more. Exercise more. Even if you've never exercised, start doing something. And the easiest thing to do is walk. Start walking. It takes no planning. You don't have to join the gym. You just have to put on a pair of shoes. And how much should you walk? At least 30 minutes a day. Okay, that's a good start. Most important thing you can do is get older. Does a blood thinner prevent strokes? So there's two kinds of blood thinners. There are what are called antiplatelet agents like aspirin, which many people take to prevent heart attacks and also to prevent certain kinds of strokes. And then there are stronger blood thinners such as warfarin, and now there are a series of new oral drugs called Eliquis and the Bigatran and Xarelto. Those are oral drugs, very strong blood thinners. The strong blood thinners are for people that have had documented blood clots either in the lung or in the leg or have atrial fibrillation. If you have those problems, you should take those strong blood thinners, but obviously you're going to talk to your own doctor about it. But if you have atrial fibrillation, warfarin or Xarelto and Eliquis, those are the drugs you want to take to prevent a stroke if you have atrial fibrillation. Somebody's worried about aneurysms here. Okay, what are the signs of an aneurysm? A small aneurysm that you're walking around with has no symptoms, none. You wouldn't know it. You just don't know it. If you have trouble from an aneurysm, it's usually because their aneurysm ruptures and you get bleeding. And when that happens, you get a really, really bad headache. So bad that you're going to say, oh my God, I'm going to go to the hospital to get it checked. And then we can diagnose it by doing a scan, either a CAT scan or an MRI to diagnose it. So if you get a sudden, really bad headache, and lots of people get headaches, but this is something worse than your normal kind of headache, then you want to go to the emergency room, call 911, come in, and we'll investigate and find out.
And this was along that line, kind of headache or intermittent head pressure, force.
All right, can headaches or intermittent head pressure foreshadow, I like that word, foreshadow, good word, and I'm going to start using it myself, an impending stroke? In general, no. Impending strokes really are not foreshadowed by headaches. A ruptured aneurysm is, wham, it's like someone hit you in the head with a hammer. It's really bad. But other kinds of strokes do not develop and do not cause headaches. So that's not something that you need to be concerned about for the most part. Yeah, that's fine. This is a question about Lipitor for treatment of a high LDL, which is the bad kind of cholesterol. And the person developed muscle pains after several years and was changed to a different statin, lovastatin. So there are about 10 different statin medications now, and some people get muscle pains from one but not another. So the recommendation is really to try different ones first. Try 3 or 4 different statins to see if one of them agrees with you better than the others. And at some point, if the muscle pains are really annoying, then you may have to stop it. But I usually tell people try to put up with it as much as you can. Some people benefit from taking a supplement called coenzyme Q10 that sometimes helps to reduce the muscle pains, and they can then stay on a statin. But I believe that statins are so effective at preventing heart attacks and preventing strokes that I think you should take them unless there's a compelling reason not to. I take a statin. My doctor didn't say I should take one, but I said, well, I want to take one. So I started taking one anyway.
I take a statin too.
Yeah, and so I think they are incredibly valuable, important medications. So unless your muscle pains are really, really bad, I would try to continue to take a statin. Why are blood pressure readings different in every office? Okay, good question. Okay, no, they are. They are. Okay, look, blood pressure goes up and down, and that's a normal process. During the course of a day, depending on what you're doing, your blood pressure may be higher or lower. So, to check it in a reliable way, it should be checked the same way each time. You want to be sitting in a chair, you should be comfortable, you should be relaxed, you should not be stressed out, you should not check it, you know, when you were late for the doctor's appointment and you were rushing in and you're all worked up and agitated. Patients come in like that all the time. I tell them, calm down, it's okay. So it should be checked when you're calm and resting and quiet, because otherwise it's going to be artificially elevated. And then a lot of people have, you know, they talk about white coat syndrome. I don't know if that really exists or not. I mean, I think it's just patients get anxious. So you want to get it while they're calm. And if you take it at home for yourself, which I think is fine, do it the same time every day. Again, after you're resting, sitting, and calm and relaxed, okay? Then you should get equivalent, reliable blood pressure readings. One other thing, if you take blood pressure at home, do not use the blood pressure machines that go around your wrist. They are very inaccurate. Do not use those. Use the one where the cuff goes around your upper arm, not the wrist ones. A lot of people like these wrist ones because they're easy to use and they're small and they're cheaper than the bigger ones. But as they say, you know, you get what you pay for. So they're cheaper is, you know, not worth it.
We have 3 more.
Yeah.
Is that-
Go ahead. No, I'll look at my watch. We're
There
okay.
was a second question on there, I'm sorry.
Oh, there's a second question? I'm sorry. Oh, what? Okay, what blood pressure do we want you to achieve? How's that? We would like the systolic, the top. You know, there's 2 numbers. There's an upper number and a lower number.
I was just talking about when one is told that they have moderate, and it's going on for many years, at that reaching 140 over 80 or 90. Is that considered okay?
Well, okay. The top number of 140, we consider that to be the upper limit.
Right.
You do not want it to go higher than 140. We prefer it to be below 140. Okay? So you use that as a guideline. And the top number is the most important number. They used to think that it was the lower number, but it's not. The top number is the most important number. Yes, ma'am.
And
The concern of calling this particular unit when you're not really having a stroke, but a fear of having a stroke. It's the fear of calling and not having a stroke
it's embarrassing.
would prevent my calling when I should.
Well,
The time element involved there is a factor.
look, we understand that, and if you didn't notice, that of all the calls we get, only one out of 3, 1/3 of them turn out to be a stroke. And that's been the experience in every unit around the world. Only 1 out of 3 turn out to be a real stroke. The other 2 are other things. And we understand that, and we're not concerned about it, and there's nothing to be embarrassed about it. Nobody's going to give you a hard time about that if it turns out not to be a stroke. In fact, we're going to say, great, we're glad you didn't have a stroke. So don't worry about that. There's nothing to be embarrassed about. The whole point of an emergency system is to have a very low threshold for somebody who is ill to make sure that you don't miss one. I mean, I learned when I was in medical school that if the surgeon who does appendectomy removes an appendix, if every appendix that surgeon removes is a sick appendix, every one, then he is missing a lot of them, because some of them should be normal to make sure that you're getting all the sick ones. So it's the same thing. So we understand that. We expect it to happen. We want it to happen, because if you need to have a clear understanding of symptoms, and you call if you're having symptoms, and if it turns out to be something else, then fine, no problem. not a problem.
That's a great question. I think there's a lot of people are
Yeah,
hesitant.
yeah, I agree. Yeah, no, don't hesitate. Nobody, don't be embarrassed. Nobody's gonna give you a hard time. As I said, I've been on a call where a health aide was apologizing. She was taking care of a woman who suddenly slumped in her chair, unconscious, and the health aide called 911, which was the right thing to do. And when we came in, she was like, "Oh, I'm so sorry. I hope I didn't do the wrong thing. I felt bad about calling 911." I was like, "No, you did the right thing. That's what we're supposed to do. That's what you're supposed to do." All right. Is there a reason? I can't read this.
Sorry.
Help me with
reason
it.
to use caution if there's bleeding, because it could be made.
Oh yeah, okay, so the question really is there a danger to give these blood thinning drugs if a person has a bleeding problem? So the answer to that is yes. And if someone has a bleeding problem, and we ask questions, do you have a bleeding ulcer? Do you have bleeding hemorrhoids? Did you have any other bleeding problem? If someone has a bleeding problem, we do not give the drugs. Now, we'll get into trouble if we don't know and no one tells us anything. That's not happened yet, fortunately. But if someone has a bleeding problem, we will not give those drugs. But we can still do the thrombectomy, okay? We can still do the procedure where we put the catheter up and pull the blood clot out. We do that even if someone has a bleeding problem. That's not a problem. All right, one more. Sir, you've been sitting there very patiently. So.
Is it covered by insurance?
Is what covered by insurance?
If you do these things, the insurance companies say, sorry, you know, what you did was fine, but since the patient had something else.
To the best of my knowledge, these are all covered by insurance. Okay, so I've not heard of any incidents where a patient suddenly got stuck with a bill for something. Okay, so that has not been a problem. So as far as I can tell.
All right. Well,
All right.
Thank you, Dr. Fink. Wasn't that? I'm very sorry about the audio-visual part of this, but hopefully Dr.